So very good morning and welcome to the Breakfast at UMHealth 2025 episode 3 and to the second topic. I'm Associate Professor Dr. Rosie Pamela, and as your moderator, I'm glad to introduce this second top speaker, Dr. Intan Suhana Zulkafli. She is the head of the Department of Anatomy here in the Faculty of Medicine. A little on her background. Dr. Intan earned her master's and PhD in anatomy and human biology from the University of Western Australia, and as a passionate researcher specializing in reproductive biology and fetal programming, she explores how adverse pregnancy outcomes influences the development of adult onset diseases. Today, she will share her thoughts on this topic entitled Placental Modifications Secondary to Maternal Hyperglycaemia Resulted in Impaired Pregnancy Outcome. The floor is yours, Dr. Intan.
Thank you, Associate Prof. Dr. Pam. She's my good friend. Thank you for agreeing to moderate this session for me. So, hi everyone. This is my second time presenting results from a placenta study performed in the department. Okay, so in this study, we are looking at the effects of maternal hyperglycemia in into the placenta. So this was done by a team of girls in the department, and together we try to find what are the changes happen at the placenta level that affects the pregnancy health overall. So maternal hyperglycemia is actually quite common worldwide. It happens in around one every 6 pregnancy, which is around 14 to 15 pregnancies globally. That's the average statistic. In certain countries, such as Indonesia, Philippines, Thailand, and some areas of the Africans, the incidence is a bit lesser, and it is even lesser in countries like very advanced countries like Australia and the Americas. But the incidence of maternal hyperglycemia is quite high in our country, together with India and the Middle East. It is happening almost 25% of every pregnancy, or 1 in 4. So if you are seeing, 4 pregnant mothers sitting side by side, one of them must be having maternal hyperglycemia, or GDM for that matter. So this statistic is expected to rise even further, and it is estimated by 2045 there will be a 30 to 50% rise in the incidence of maternal hyperglycemia, and this is because of economic proliferation in all these countries. So in terms of economic burden and healthcare burden, we are going to see this more in the clinics. So before I talk further about the effect of hyperglycemia onto the placenta, let me introduce what is a placenta. Placenta is a temporary organ that develops during pregnancy. It is there only, like in human, only for the 9 months of pregnancy duration. In rats, only for the 3 weeks of pregnancy duration. So the placenta attaches to the uterus to support growth and survival of the developing uterus. This is the surface that attaches to the uterus, whereas this is the umbilical cord that connects to the fetus. So through the placenta, substance like oxygen and nutrients get passed through the placenta into the fetus, whereas urea and carbon dioxide are removed from the fetus through the placenta. Other than that, placenta also performed protective function, so harmful substances are repelled from the fetus by the placenta, and placenta is also able to perform metabolic function, in which certain substances like lipid and iron can be stored inside the placenta for fetal use. Last but not least, placenta also perform hormonal function for the fetus by secreting all these hormones that support fetal growth as well as parturition. So with all this multifaceted function of the placenta, it is very important that the placenta is healthy to be able to support pregnancy throughout the pregnancy duration, which is 9 months for human and 21 days for rats. Human and rats placenta are very much similar because they are discoid and hemochorial. And so in order to look at the effect of hyperglycemia. So we know that in hyperglycemia, there is an excess levels of sugar or glucose in the mother that and because this glucose is considered as nutrient, so glucose can easily pass through the placenta into the fetus. So the excess glucose cannot be good for the fetus, and that's why we are seeing hyperinsulinemia in fetus of diabetic mothers and other problems related to that. But what actually happened to the placenta? Because we all know that placenta is a organ that has developed its own plasticity, whereby it can actually respond to the environment and adapt to the situation in order to support the fetus. So from literature, we have seen that, the placenta actually suffers from oxidative stress and inflammation due to the hyperglycemia itself. Okay, so that's why we are seeing a lot of maternal complication due to maternal hyperglycemia, which includes co-development of hypertension during pregnancy, increased risk for cesarean delivery, uncontrolled blood sugar during pregnancy, which has a lot of complication to the baby as well. And there is also a long-term risk for developing cardiovascular disease in later life. In babies, we are also seeing, due to the excess sugar released from the mother, the baby develop hyperinsulinemia. The excess levels of insulin leads to growth hormone effect, in which we are seeing a lot more of macrosomic babies, and then which also related to difficult delivery, so on and so forth. There's also risk for respiratory distress syndrome, and in some very, very badly controlled, poorly controlled hyperglycemia, baby tend to be very, very small, and they are also at risk of developing long-term obesity and metabolic syndrome. So what happened to the placenta? Was the placenta not able to cope with the stress of maternal hyperglycemia? That was the question that we asked ourselves when we designed the study. And we suspect there's some level of placenta remodeling happening in this kind of situation. So in order to do that, we adopt the chemical-induced hyperglycemic pregnancy rat model, specifically trying to look at the effect of hyperglycemia, the excess of sugar on the placenta. Okay, so we took 6 to 8 weeks nulliparous female Sprague Dolly rats and monitor their estrus cycles and mate them with fertile male during proestrus overnight. Okay. And then the control dams receive 0.1 molar of intraperitoneal citrate buffer saline, pH 4.5, freshly prepared every morning at gestational day 7, whereas the hyperglycemic dams receive 45 milligram per kilogram of intraperitoneal streptozotocin at GD7. So we have done a little bit of pilot study to find out the best dosage for streptozotocin, and 45 mg per kg seems to be the best dosage for this group of rats. So we bred these dams for 15 days until GD15, and we collect the fetal placenta unit, and also at GD21. So what we're trying to see are the outcomes of the pregnancy, the placenta outcomes in terms of morphology, biochemical, and molecular changes. So here are some of the results that we have had so far. We don't have all the results yet. Okay, so in terms of model confirmation, we did fasting blood glucose on these dams, and evidently those dams who receive streptozotocin injection displayed hyperglycemia at GD13, which is 1 week after induction. So just a little bit of explanation about streptozotocin. It is a toxin that is injected to specifically attack the beta cell in the islets of Langerhans, and this will be so toxic and reduce result in absent insulin secretion. So without insulin, sugar cannot be absorbed into the cell, and because of that, the mothers will develop hyperglycemia. Next, we look at the pregnancy outcome. We monitored maternal daily weight, and you will notice that there is a reduction of maternal weight in the hyperglycemic dams, the one characterized with the dotted lines here. So it is interesting to see, because when we measure their average food intake, they are actually the hyperglycemic dams are actually eating more than the control dams. Okay, there is a little bit dip in their food intake right after the induction with streptozotocin, as they're trying to recover from the insult, but they were really eating their way up lah, their body weight. But there was no healthy body weight gain during this pregnancy for the hyperglycemic dams. So we figured that the excess glucose in their system were not able to be absorbed or utilized by the cell because absence or very, very lack of insulin. Therefore, they are suffering from cellular energy starvation, which induce polyphagia in these dams. And then we look at, fetal outcomes. Okay, and one of the things that we look at the outcomes of the fetus is looking at fetal resorption. And in research, fetal resorption basically means that the pregnancy is being absorbed back by the body because the body is not able to sustain the pregnancy anymore. This is equivalent to miscarriage in a human. So what we see in the hyperglycemic groups that have been injected with streptozotocin, there's 12 folds of fetal resorption compared to the control dams. We didn't see any resorption in the control groups. And then in terms of fetal body weight, we are seeing 0.25 folds reduction of the body weight for fetus of hyperglycemic dams. So there's a lot of sugar available in the mother and also in the fetus. We are expecting that this, excess nutrients will induce macrosomia, but instead we are seeing smaller body weight fetus. So what was happening is this placenta remodeling that tried to keep the pregnancy, preventing it from resorption, but because of that, the fetus size is now being reduced. So naturally, we would look at the placenta. We measured placenta weight, we measured placenta volume, and we measured placenta density. And unfortunately, we didn't see any changes in the size and the look of the placenta at all compared to control. They look exactly the same. But how come they are not functioning the way they are supposed to be? So we look at fetal placenta weight ratio, and this ratio really is reduced in the hyperglycemic dams, indicating there are larger placentas there, but their fetuses are much smaller. Okay, this simply indicates a lack of placenta efficiency, or the function of placenta have been reduced simply because nothing else, just hyperglycemia. So as anatomists, we are interested in what is the structural changes that happens to the placenta. So we look at the histology of this placenta. Okay, and then what we see is the rightful thing to see is whether glycogen cell deposition would increase, because knowing that there is excess sugar. So in the control animals, you can see that the glycogen cells is slightly different morphology compared to the surrounding trophoblastic cells, because they are having clear cytoplasm with very dark central nuclei. In hyperglycemic dams, we are seeing increased areas of these cells in the placenta at the junctional zone. No difference was seen at the labyrinth zone of the right placenta. So we also quantitate these results, and we found that indeed there is an increase in the areas for glycogen cell deposition in the junctional zones of both placenta at both timelines at GDU15 and GD21. So next, we also look at maternal vascular spaces. So these vascular spaces are very important because that is where nutrient and oxygen exchange happens. And if any alteration in vascular space means it will support the reason why the fetuses are smaller. So from the quantitation that we did, we noticed that there's supposed to be an increase in the maternal vascular space at GD21 in the labyrinth zone, but we did not see that. That increase did not happen in the labyrinth zone of the hyperglycemic dams. So there is an expansion failure in terms of the maternal vascular space for the hyperglycemic dams. So that's all about the results. So this is the conclusion that we have. So here you have the control placenta with the labyrinth zone facing the fetus and the junctional zone facing the mother. So what we are seeing in the hyperglycemic placenta is that there's increase of this glycogen cell deposition in the areas where trophoblast cells supposed to be here. So glycogen cell clusters are much more at the junctional zone, and in the maternal sinusoids are not expand as it should be as the pregnancy progress in the labyrinth zone. So considering that there is no insulin available, it is interesting how placenta is able to absorb this glucose and then convert it into glycogen and save it inside the placenta itself. So happen that placenta does not utilize insulin, instead utilize insulin like growth factor 2 to actually absorb sugar. So with all this excess of glycogen cells in the labyrinth zone, there's a reduced surface area for nutrient transfer and therefore reduced fetal body weight. Right now, we are still doing further analysis on the placenta by looking at the expression of vascular markers, expression of specific inflammatory markers, and evidence of advanced placental aging. And the reason why we are interested in placental aging is because we are seeing a lot more of advanced aging in not even term placenta in mothers with gestational diabetes. I mean, in human population with calcification, necrosis, and so on and so forth. So we are trying to look at that in the red placenta, but we are finding it difficult because the pregnancy duration in human is much longer, which is 9 months, and the pregnancy duration in rat is only 21 days. Therefore, the anatomical or the structural anomalies might be lesser in the rat compared to human because just purely because of the spatial effect. So we are trying to get some markers for placental fibrosis and also placental microcalcifications to see if there's any evidence of advanced aging. Okay, finally, I would like to acknowledge these team members that have helped me with this research and also to acknowledge Fundamental Research Grant Scheme that have funded this research. Thank you.
Thank you very much, Dr. Intan, for sharing such an interesting topic. And it is very crucially essential knowledge in the field of fetal programming, right? And also precisely the placental remodeling and also fetal development in hyperglycemia. Truly an interesting and needful topic to be shared today. I don't see any questions. So I think that sums up the topic today. And thank you everyone, all our viewers online as well, for joining us on Breakfast at UM Health 2025. Thank you everyone.
Thank you.